This is the Emergency Medicine Clerkship Pharmacology module. We are going to be covering practical topics related to pharmacology of pain management, rapid sequence intubation, procedural sedation, and shock. First up, pain management. This is quite an extensive topic, something that we could probably spend several hours on. We'll keep it brief and just really cover the high points of how to use pain medication practically in a busy ED shift. Before you sit down to enter an order for any pain medication, there's some things you need to think about first. Number one is you have to assess the patient's pain. How bad do they hurt? How much do you need to bring down their pain? The most common way to do this is the 0 to 10 scale. Some people qualify it with mild, moderate, severe. There's a FACES chart in pediatrics and so on and so forth. Other things to consider: how intense is the pain? How long is it going to take for the medication to work? And then, as a byproduct, how long is it going to work for? Which route of administration is accessible to you? Is the medication going to be safe for this patient at this time? And is it going to work? The general categories of pain medication that you can use in the emergency department especially are NSAIDs, Tylenol, opioids, and then local anesthetics. On to NSAIDs, the common ones you'll hear of are aspirin, naproxen, which is Aleve, ibuprofen, which is Motrin, indomethacin, and then ketorolac, which is Toradol. Just a very basic refresher. NSAIDs work by binding COX-2 receptors to produce their analgesic effect, and then they work to decrease the release of prostaglandins and arachidonic acid to produce their anti-inflammatory effect. In general, the good part about NSAIDs, there's no sedation, no risk of respiratory depression, you don't have the side effects of constipation. By and large, they mostly produce platelet dysfunction, some renal dysfunction, and then GI bleeding or upset. Here's a chart just to kind of compare everything all in one place. I included Tylenol at the top. We're not going to read through all the doses, but there are some of the most common dosings for each medication. The dose on aspirin is higher when you're using it as an analgesic, which is not very common anymore. Down at the bottom, ketorolac, it's available IV, it's available IM. There are PO formulations, and there even are intranasal formulations. For a long time, that was really the main parenteral NSAID that you could give. Tylenol now has a IV formulation, but it's not very commonly used. As you can see on the right, most of the common NSAIDs have the risk of GI upset and GI bleed, renal dysfunction, platelet dysfunction. Aspirin has its whole set of side effects, and Tylenol, of course, liver dysfunction. Onto NSAIDs, or onto opioids. Things to think about before sitting down to order opioids for somebody. Each patient is going to have their own dosing, and that means opioids, you can develop tolerance to them. So someone who's been taking an opioid for 20 years is going to get a much different dose to produce the same effect as someone who's never taken an opioid. You also have to consider the side effects before you sit down to order someone an opioid. There's also the epidemic countrywide of opioid dependence. The rate of prescription opioid related overdoses and death is rising dramatically. On the flip side of that, some pain management specialists say that we are dramatically under-treating pain, and especially chronic pain. That's probably all we'll say about this debate, but just to know that it's out there, and it's something to keep in mind as you move into the middle of the debate, as you start prescribing these medications for yourself. Demerol may have been something that you've heard about. It's an opioid that's fallen well out of favor, really not used anymore, primarily due to its the risk of buildup of toxic metabolites. Codeine is another opioid that you will hear about. It also should not be used as a analgesic, in my opinion. Usually produces more GI upset than pain control. There's just better medications out there that will do the job more effectively for you. Here's a chart to get all the common opioids all into one place right in front of you, with the dosing, the timing, and their most common side effects. These are the common names: morphine, Dilaudid, fentanyl, are really the IV or IM formulations. Then oxycodone, hydrocodone, tramadol are the oral formulations. And again, we won't read through all the doses. Under timing, note that, for instance, morphine, the difference in onset, peak effect, and duration is different between IV and IM. You may have thought or wondered at one point, well, why did they give fentanyl during that trauma, per se, or for example, as opposed to Dilaudid? Well, the answer is next to the onset under timing. Fentanyl takes less than a minute to start working, as opposed to Dilaudid, which takes 3 to 5 minutes. So when time is of the essence, and we've got to get that patient off the backboard and off to CAT scan, treating their pain and getting something working immediately is the primary concern, so that we can move on with taking care of the patient. Now you may wonder, why don't we do that for everyone? Why don't we give fentanyl to everyone? Everyone gets good pain control right away. And the answer is under the duration, under timing. Fentanyl lasts less than an hour when administered IV. It's really almost nothing. Whereas Dilaudid lasts 2 to 4 hours when given IV. Fentanyl shouldn't be used for routine pain control unless you have some good reason to use it, such as allergies or an acute situation that you're dealing with. If you're redosing a pain medication in every hour, you need to rethink your strategy, because you're wasting a lot of your own time and your nurse's time. Look down at oxycodone and the other oral formulations. Those are the common dosages. Typically will kick in between 10 and 30 minutes, and they can last up to 6 hours. This is the other common chart, which gives you the equipotent dose, or in other words, if I'm giving 6 milligrams of morphine and I want to switch to Dilaudid, how much should I be giving? So you can see, and this will be a little bit different depending on which resource you look at, but by and large, morphine 10 milligrams equals about 1.5 milligrams of Dilaudid. On the same page, 10 milligrams of morphine equals about 100 micrograms. That's not a typo. Fentanyl's measured in micrograms. 100 micrograms of fentanyl. So if you look back on the previous slide, morphine typical starting dose 0.1 milligrams per kilogram IV. For the average 70 kilogram adult male, that's about 7 milligrams of morphine. You may decrease that a little bit for opioid naive patients, and this is where you get to approximately that 4 milligrams or 5 milligrams starting dose that you've probably become accustomed to for morphine. Going over, you really won't use oral morphine or Dilaudid or the transmucosal formulation of fentanyl. You won't be prescribing that, at least in the ED. You should be familiar with it if your patient comes in with it who's in chronic pain. But you can also see there what the equivalencies are. Interestingly, the resource that this is coming from states that oxycodone and hydrocodone are equipotent. I would have to say I disagree with that. If I were making this, I'd say oxycodone is about 30 milligrams and hydrocodone is maybe 25 milligrams. I should reverse that. Hydrocodone is 30 milligrams and oxycodone is about 25 milligrams. Nonetheless, that's what we're going with, equipotent. And tramadol is about 10 times the dose. Special considerations when you're dealing with someone with neuropathic pain such as sciatica or something similar, don't forget about Neurontin. In migraines, especially in the ED, do not use opioids. They really don't work that well and come with all the side effects. Studies have shown you get up to 95% success with the usual antiemetics such as Reglan, Compazine, and Phenergan. Beware of extrapyramidal symptoms, so that's why you'll see a lot of people give Benadryl with it. Don't forget about prolongation of the QTC, something you should always kind of keep in the back of your mind when you're using these medications, especially. The most common migraine cocktail that you see in the ED is usually 10 milligrams of Reglan, 25 to 50 milligrams of Benadryl, and then 30 milligrams of Toradol, either IV or IM. Then we move on to anesthetics. Briefly, there's a topical for intact skin, there's topical for open wounds, and there's mucosal. Here at Loma Linda PTD we use LMX, which you put on there on intact skin, leave it for 20 or 30 minutes, and then come back and you should be ready to go. For open wounds, it's something called LET, and again, 20 to 30 minutes, you come back and you should be ready to go. For mucosal, that means hurricane spray. That's something that you'll use maybe in the pharynx when you're, say, getting ready to drain a peritonsillar abscess, and you spray this back there. Then you inject some lidocaine, and then you're ready to go, and you have pretty good success. You can also use viscous lidocaine to spit and swish and spit if you're looking for pain control over some mucosal surface, intraoral or something like that. Real briefly here, just want you to know local anesthetics are divided into two categories. One is amides, one is esters. It's something that you should be familiar with. The way to differentiate the two, amides the name has an I in it. All the drug names under amides have 2 I's in their name. Bupivacaine has 2 I's, lidocaine has 2 I's, whereas esters has no I in it, and all those just have 1 I in their name. Is that important? I don't know. The only time I've ever used it is on a standardized test, but it is what it is. Thought I'd pass it along. Looking here on this chart, the important thing to know, several important things to know. Lidocaine comes with quick onset. This is plain lidocaine. Quick onset, 5 minutes. I think it's even shorter than that in practice, and it lasts up to an hour. You can extend that duration when you're using it with epinephrine. Bupivacaine, on the other hand, takes a little longer to kick in, 10 to 15 minutes, but it lasts 200 plus minutes. Notice it doesn't say how long. I've had some patients tell me it lasted 8-12 hours and they had no pain after using it. This max dose, notice that there's a max dose. There is something such as lidocaine toxicity. That's a real thing. So sometimes the size of the wound is the limiting factor on when you can repair it at the bedside and when you have to go to the operating room. Moving on from pain management to rapid sequence induction and intubation, shortened as RSI. You may see some people call it RSII. This is when you give a sedative at the same time as a paralytic with the intention of intubating a patient. It is the almost universal way of doing it in an emergency situation. Some things to consider. We're not going to cover the technique of intubating now. We're going to try and limit ourselves just to pharmacology. Some things, pharmacology that's related to intubation. There's this notion of pre-treatment. You pre-treat for this and that. None of it really works. So you'll hear about maybe using lidocaine before you intubate a patient and paralyze them to treat for elevated intracranial pressure. Never really been shown to be useful, really kind of fallen out of favor. Atropine has been talked about in the pediatric population to prevent bradycardia in children. You get that reflex bradycardia is theorized with the pharyngeal stimulation while you're intubating. Really hasn't been shown to be that useful. It can be useful if you are treating bradycardia, but to prevent bradycardia, it's really not that helpful. And then rocuronium at the bottom there has been talked about as a defasciculating dose. Again, sometimes for elevated intracranial pressures or other such scenarios. Is really also not that useful and falling out of favor. These are the common induction agents. Etomidate has been the most common for quite some time. Propofol is catching up with it. And then ketamine, definitely a distant third for induction in RSI and the ED. You can review the doses. We're not going to spend time reading those to you. This is a chart comparing the pros and cons of each medication. These are things that every provider is thinking about, either consciously or subconsciously, while they're preparing to intubate their patient. Etomidate, the good part about this and why so many people like it. There's really no effect on blood pressure. It can't even decrease intracranial pressure and intraocular pressure. If you think about it, most of the patients that we're dealing with, emergency intubations, are hypotensive or hemodynamically unstable. So giving a medication that makes that worse is less than desirable. So etomidate is useful for that reason. The negatives of etomidate: there's no pain control with it. You can also get myoclonus and seizures and even vomiting in patients who are awake. This is more common with etomidate when it's used for procedural sedation. When you use etomidate followed by a paralytic, there really is no myoclonus that you get with it, so it's really a non-issue for RSI. The onset of etomidate is extraordinarily fast, less than a minute. You have a sedated patient for 10 to 20 minutes, which is really just ideal timing. Propofol, the good part about that, it's an antiemetic, it's an anticonvulsant, so you can imagine which type of patient you would want to use propofol in when you're intubating them. The negatives of propofol: when you bolus dose this, you can see significant degrees of hypotension, which could just make your situation that much worse if you're already dealing with an unstable patient. You do have the side effect of apnea. However, that's also a non-issue during RSI, because that's really what you're going for. You're about to push a paralytic. It's really a non-issue. The onset for propofol very fast, and the duration also pretty ideal. Ketamine, there are some scenarios where ketamine is good. This creates it's described as a dissociative amnestic. So you'll see the patient with their eyes open, but they're glossed over. They're definitely not on the same planet as you and I after you've given ketamine. The really most common clinical application for ketamine is using it for its bronchodilator effect. You can also imagine what type of scenario you would want to use a sedative with a bronchodilatory effect in a patient who's requiring RSI. The negatives for ketamine: you can increase secretions, you can increase blood pressure, and then there's this emergence phenomenon, which is more important with procedural sedation, because most people who are intubated are started on a sedative drip following. So ketamine, also quick onset, relatively short duration, pretty good timing. The paralytics, there's two classes. One is depolarizing paralytic. This is succinylcholine is the one that you're going to hear about and see used during your rotation. The dose is really 1 milligram per kilogram as the most commonly used dose. You see the onset there under a minute. Very ideal when time is of the essence. It gives you a paralyzed condition for between 5 and 10 minutes, which is usually more than enough to intubate a patient. However, if you have a difficult intubation and you failed 1 or 2 attempts, you can run into an issue where your paralytic's wearing off. You have to redose. Also, to consider, if you have an impossible intubation and all your backup methods have failed, all you have to do is bag your patient if you give them succinylcholine until it wears off, usually in 10 minutes. Then you're back to a hopefully spontaneously breathing patient. Side effects from succinylcholine, the biggest one by far is hyperkalemia. So you can imagine again, which patient you would not want to use succinylcholine in? Those who are the ones who are at high risk for hyperkalemia. You also don't want to use this obviously in people who lack the cholinesterase enzyme to break this down. You can have prolonged paralysis in folks who lack that enzyme. You can see malignant hyperthermia with this, and you can also see bradycardias. Back to succinylcholine, you really don't see this used in pediatric populations much, at least in the very young, because there's concern that there may be a undiagnosed neuromuscular junction disorder that would preclude you from using succinylcholine. So you typically will stay away with it in the very young pediatric population. On to the non-depolarizing paralytics, the most common but not the only, rocuronium and vecuronium. Rocuronium is gaining in favor in emergency departments around the country. The dose there, 1 per kilo. Vecuronium is 1/10 of that, 0.1 per kilo. You see, the onset is not the problem. It takes a minute or a few to kick in, whereas vecuronium is about the same. The problem really is the duration, up to 45 minutes of paralysis for both. That becomes a big issue if you have someone who is impossible to intubate. Then you're left with either using the bag valve mask until the medication wears off, or something like a cricothyrotomy if you're not able to ventilate the patient. So on to procedural sedation, shares much of the same agents as the induction agents in RSI. Procedural sedation, this is quite commonly used in the emergency department for painful procedures where local anesthetics or systemic analgesics are inadequate. The key for procedural sedation is monitoring and preparation. Assessment of the patient and preparing are really critical steps for any sedation to go well. So before you start a sedation, you should really do your best to treat that patient's pain. You want to pre-oxygenate the patient, put them on all your monitoring devices, cardiac monitor, pulse ox, capnography, which measures end-tidal CO2, and then you can administer your sedation agents. Again, like I said earlier, similar agents to the induction agents of RSI. Propofol is the same dose as RSI, 1 per kilo, same timing, and same, actually, side effects. Apnea now is a problem in procedural sedation, and that's not what you want. You want the patient to maintain their own airway, as well as you can get the hypotension still with it. Etomidate, really not commonly used for procedural sedation. The dosing is different. It's half the dose of the induction dose. The timing is the same, but then you can see the myoclonus, which will become a problem if you're, say, trying to maintain cervical spine instability. You can also see some adrenal suppression, if that's a consideration, but again, less hemodynamic effect. Ketamine, there are 2 routes, and there are instances when you would need to use or want to use the intramuscular route. The dosing is different, the onset and duration are different. Again, the patient will maintain their ventilatory effort. There's less hemodynamic effect, but you will get salivation, you will get this laryngospasm, which usually resolves on its own or with a bag valve mask, and the emergence reaction, which is essentially having a terrible nightmare. The patient will thrash and scream and make all sorts of ruckus. It's very disconcerting to you as the physician, let alone to the patient and or their family. Back to the route of administration for ketamine. You can use this if you don't have IV access under an emergency basis. It's not ideal, but if it's what's best for the patient in that situation, then that is an option for you. Say for an agitated patient who you just need to get under control for the patient's safety and the staff's safety, if nothing else is working. Or you may want to think about the IM dose even if you have an IV established, because the duration is a lot longer. So if you can imagine you're by yourself doing your own procedure, and you don't have time to keep redosing your sedative, you can push 4 milligrams per kilo of ketamine IM, and you have up to an hour to do your procedure. Whereas if you gave it IV, you have maybe 15 or 20 minutes. Fentanyl and Versed, you can look at the doses there. Relatively long duration, and you get the same side effects as what you would expect with the opioid and the benzo, respiratory depression and hypotension. Propofol by far the number one most common procedural sedation agent in the ED, probably followed by ketamine and then fentanyl and Versed. Etomidate by far and away the least common sedation agent. And finally on to shock. This is a very expansive topic, and we're not going to get into any detail about anything other than the pharmacology, but just a quick refresher. Shock, if you think about it as an imbalance between the circulation, an imbalance between oxygen consumption and supply. You can then break that down into causes. Hypovolemic shock, most commonly seen in trauma, also sometimes seen in GI bleeds. Cardiogenic shock, you can think about in acute heart failure, maybe due to an MI. Obstructive shock, the least common of the four in the emergency department, but you may see that in acute pulmonary embolism. And then distributive shock, probably the most common shock you'll see in the ED, even before hypovolemic shock. This is septic shock. The most common agent used in shock is actually not pressors, it's IV fluids, and that's the next slide. The most common table that you'll see related to shock is this one. So I wouldn't get bogged down in memorizing this word for word or column by column. I also wouldn't get frustrated if you compare this to the reference or table that you undoubtedly already carry in your pocket, because this table that I have produced here is probably different than the one that you keep in your pocket or in your textbook. I would focus more on getting the general ideas and the main classes of medication and how they tend to work, as opposed to trying to figure out the minutia at this stage of your training. So number one most common vasopressor is Levophed. It's on the number 2 line there, or norepinephrine. You can see the dose. It acts at alpha 1 and beta 1 receptors, produces a large degree of vasoconstriction, and cardiac stimulation to a lesser degree. You'll typically move on to vasopressin after that. You usually will start that at 0.04 units per minute as a non-titratable vasopressor. You start it at 0.04 and leave it. That's never the first pressor. It's always going to be a second or third option, or addition, should I say. Or I should say, you're never going to have someone on vasopressin only. It's always in combination with something else. That's alpha receptor activity produces all its effect by vasoconstriction. Epinephrine usually will be third choice. You see the dose, non-selective alpha and beta receptor activity. It produces a lot of cardiac stimulation and vasoconstriction by both of these receptors. That has a positive effect on cardiac output, but you also see a lot of tachyarrhythmias, and you also increase the myocardial oxygen consumption by making the heart work so much by stimulating it. So there's pros and cons when you're having someone on an epinephrine drip. Dobutamine, really kind of reserved for rare instances. It's by no means a routine vasopressor. And then back up to the top, we didn't forget about dopamine. Dopamine has fallen way out of favor, especially in the emergency departments, I can say for sure, but also in the ICUs. It just has too much variability. It produces far too many tachyarrhythmias when that's something you're usually combating already. And there is some good research done quite some time ago now comparing Levophed to dopamine directly, and Levophed was a clear-cut better choice. So dopamine really kind of falling by the wayside recently. And here's what you're titrating to typically. One or all of these. Urine output, you want to keep up at half a cc per kilo per hour. People don't titrate to central venous pressures of 8 to 12 millimeters of mercury, but that requires a high central line, which high central line means subclavian or IJ central line. You titrate to MAPS, mean arterial pressures of 65 or greater. And then there's also the IVC collapsibility index. This is a relatively new thing. It requires an ultrasound. You measure the IVC, and if it collapses greater than half of its diameter on inspiration, then you are considered volume depleted, and you need to quote-unquote fill the tank before you're ready to start vasopressors. So this is not something that you titrate a pressor to. It's actually a way of determining whether you need pressors or not, or whether you need a fluid to resuscitate the patient. Speaking of fluid resuscitation, the big categories of fluid that you'll use to resuscitate a patient: crystalloid, that's normal saline or lactated ringers. There are pros and cons of each. It's been studied, and there's really no superiority of one over the other. So essentially, it's your choice. And at least here in our emergency department, normal saline. 99 times out of 100 is what we reach for. There is this thing called colloid. It includes things such as albumin, FFP, and hetastarch. Really not commonly used at all in the emergency department, if ever. And then packed red blood cells. You can use this for resuscitation, mostly in hypovolemic shock, occasionally in septic shock. There is, going back to this fluid resuscitation slide, the typical resuscitative measure, especially in a trauma, which would be hypovolemic shock, is to give 2 liters of normal saline rapidly. If the patient doesn't respond to that, then you presume that they are so hypovolemic or have lost so much blood that 2 liters is not going to, or hasn't resuscitated them, that now they need actually replacement of their hemoglobin and their oxygen carrying capacity, and that you're never really going to get there with just crystalloid alone. So you move on and start transfusing uncross-matched or cross-matched blood, depending on your timing and critical nature of the patient. So usually 2 liters, 2-liter bolus of normal saline or LR, and if the patient's unresponsive to that, meaning they're still hypotensive or tachycardic, or they only transiently respond, they get better but only for a few minutes, then typically most places will move on and start transfusing PRBCs. Last but not least, antibiotics, and we're just going to talk about this very briefly. Again, like I said, a very expansive topic is shock. This would be in distributive shock, is when you're thinking about using antibiotics. And antibiotic administration in the ED is actually pretty easy. Either you know what it is, what the pathology is, and you know what the treatment is for it, or you look it up because it's something that's easily found. For instance, the patient has acute otitis media, very easy antibiotic choice. The patient has cellulitis, okay, fine. You cover for MRSA or you don't. The patient has a urinary tract infection. Sure, you look at your hospital's antibiogram and pick which one covers your gram negatives most effectively. Or, in the emergency department, you don't know what is going on, and then you start empiric antibiotics. The most common by far empiric antibiotic regimen in the emergency department is vancomycin and Zosyn. The reason for that, vancomycin covers MRSA as well as your gram positives, but specifically it expands to MRSA, and Zosyn will cover your gram negatives as well as Pseudomonas. So in that, gram positive, gram negative coverage, MRSA and Pseudomonas coverage, and you've got all your main pathogens covered. Obviously there are special circumstances that you may want to think about, whether you need to cover anaerobes or fungal or viral or stuff like that, but most commonly vancomycin and Zosyn will do it for you. With that being said, if you have allergies or if you feel like being creative, you can come up with your own regimens, just as long as you're covering for MRSA and Pseudomonas, gram positive and gram negative, you'll probably be just fine. Some other considerations: the neutropenic patient or the neutropenic fever, empiric coverage, you give cefepime. That's something that's different than the usual broad spectrum vanc and Zosyn. And then in the neonatal fever, we won't get into the gory details of all this, and the peds attendings may practice differently in specific instances. However, from 0 to 4 weeks, you're usually giving ampicillin and cefotaxime. From 1 to 3 weeks, good old Rocephin, usually by itself. Then for anyone greater than 3 months, good old Rocephin again, plus or minus of vancomycin. And that about covers antibiotic administration in the ED, and that about covers our pharmacology module. Thanks a lot.